And why this topic? Basically to raise awareness about the organizing pneumonias. And organizing pneumonias are rare inflammatory lung diseases characterized by granulation tissue in alveoli as well as alveolar ducts. They can be also in the bronchiolar tubules or lumens, in which case you call them bronchiolitis obliterans, and this is the old term, but this is now reserved for the secondary pneumonias. Shortly, I'll just tell you about secondary and primary pneumonias. They can be classified according to 3 criteria. If there is an identifiable cause, that like radiation, exposure to fumes, birds, or respiratory infection, that's one cause for an organized pneumonia. Another is if the pneumonia occurs in the context of a known disease or condition like connective tissue disease or an immunological disease like sarcoidosis, then yeah, that's also another thing to explain an organized pneumonia. If none of the above is present, then and you don't have any cause, then this is an idiopathic or cryptogenic organizing pneumonia. When should we think about the cryptogenic organizing pneumonias? You know, they are rare pneumonias, so you don't think about them when the patient is admitted to the hospital. Usually common things are common, like community-acquired pneumonia, because most of our patients are admitted with community-acquired pneumonias. And this brings us to the community-acquired pneumonia mimics. So if you are treating a patient for a community-acquired pneumonia and you feel things are not really fitting in very well with that, then you need to exclude the mimics for the community-acquired pneumonia. Of course, common things are common, like pulmonary edema, PE, malignancy, immunological conditions. You have rare as well as common immunological conditions, drug toxicity, and radiation pneumonitis. Now, when do you say you have excluded your mimics is when you do your microbial testing like sputum culture, blood cultures, and still you're getting no growth and you cannot really identify any organism growing. And there is poor response to your antibiotic courses. You change the antibiotics, again, there is no response. You think, okay, maybe you need to offload the patient, you give them diuretics, nothing happens. You do an echo to double check that, it comes out essentially normal. You do a CTPA and there's no PE, and you exclude malignancy with CT tap. Again, from the history, there's nothing to suggest an exposure like radiation or fumes. And then you further investigate by doing autoimmune screen or vasculitic screen, and then you get other inconclusive results or titers that the rheumatologists are not interested to look into. So this is when you start thinking that something else, something rare is there, like cryptogenic organizing pneumonia. The epidemiology of COP is, the incidence is 1 in 200,000 inhabitants. Usually men and women are affected equally. It happens in the 5th and 6th decades of life, but it can happen before that and after that as well. Smoking is not a precipitating factor in the sense that they can be non-smokers and still get it. Pathogenesis is not really clearly understood. Clinical features. So the patients can present with flu-like illness, fever, malaise, and cough, and the cough is usually non-productive cough. They also can present with some breathing difficulty and dyspnea. They must have visited their GP, received 2 courses of or more of antibiotics, and this has been going on for weeks. Usually 2 to 3 weeks. It can go up to 2 months, but usually less than 2 months. When you examine your patient, they'll be having inspiratory crackles, and if wheeze is present, it will be heard along with the crackles. An interesting thing about COP is the migratory nature in some of its presentations, because it presents widely in different ways. I'll give an example of how this can be seen. Migratory, the GP tells you that this patient presented to me for the past 3 weeks with the above symptoms, and I did the chest X-ray, and he or she has consolidation on the right side. You take the patient, repeat the chest X-ray, but the consolidation is on the left side. Now, did the GP mix up the sides? No, he's not mixing up the sides. It is actually the nature of the disease that it can resolve from one side and go to the other side. And it can also appear and reappear on the same side. Now, another interesting thing about cryptogenic organizing pneumonia is its rapid response to steroids. Within days, you see dramatic improvement in steroids. Investigations. We do the routine investigations, and of course, we start thinking about that when we have excluded our common problems. So, routine bloods will show leukocyte proteins and array CRP. And if an ESR is done, particularly in the initial phase of the disease, it can be up to 100,000, or it can be up to 100 or even above that. You need to do sputum culture to exclude infective causes, blood cultures, chest X-ray, your autoimmune screen, avian precipitants, as I explained earlier. You need to do an HRCT, pulmonary function test here, show a restrictive pattern. And we don't like to resort to invasive procedures like bronchoscopy, BAL, and transbronchial biopsy unless we are really in doubt and we need to exclude other causes like malignancy or eosinophilic pneumonia. I'll speak more about chest X-ray and HRCT findings. So the chest X-ray findings are very diverse, but typically you have bilateral consolidative changes or ground glass patches, and they can also be diffuse. For example, here. Usually it has predilection for the lower lobes, but it can happen anywhere. If you see that the distribution is peripherally, like in this figure over here and over there, you need to think about the differential of eosinophilic pneumonia. And about the migratory nature, the GP has done an X-ray, it was on the right side. A week later or so, you repeat the X-ray, it is on the left side. So yeah, it does migrate. It can be on one side, unilateral, but it's mostly bilateral. It can also be, you can also have nodular opacities, and rarely you can get pleural effusions with that. HRCT, the same things mentioned for the chest X-rays, but of course more details. Here you can see these are the bilateral lower lobes, and you can see that there are parenchymal consolidations. And on the next figure, you can see that we have focal pulmonary parenchymal consolidations. These are focal, okay? And on this one, you can see this. Now, we need to be careful here, of course. Obviously, I think most physicians will not think about cough as the main cause for this. You think about malignancy as a possible cause for this, radiographic appearance. Vasculitis is another possibility, and infection. So when you've excluded all your common ones and more sinister ones, probably you need to go for further investigation evaluation to reach your diagnosis here. Another presentation is with air bronchogram. You can, it very much mimics the community-acquired pneumonia, like strep pneumonia, for example. And here you can see another presentation is asymmetrical crazy paving pattern of both the upper lobes. As I said, it does not necessarily happen. Mostly it happens in the lower lobes, but it can also happen in the upper lobes. Histopathology, that is when you actually go for an invasive procedure and you take, it's characterized by proliferation of the granulation tissue that's consistent of loose collagen, wet fibroblasts, and myofibroblasts. I think the histopathologists and the pathologists would be more interested in this than us clinicians. So it's very important to remember that it is a multidisciplinary diagnosis, and when you've exhausted all your other possible common causes, only then you start thinking about it. Mainly, it's a clinical radiological criteria diagnosis. We don't resort to lung biopsy, but we do that, as I said earlier, only if you're in doubt and if you want to exclude sinister causes like malignancy. The diagnosis is made by physicians, radiologists, plus minus pathologists together. Now we go to treatment. It depends on the presentation of the patients, either cold or hot. If symptoms are mild and the X-rays are not angry looking, then it's mostly dealt with by the GP and probably the specialist clinics of IMD as an outpatient. And in which case they will be given mostly prednisolone and followed up. That's just briefly. I will speak more in detail about the inpatient management, which is the management of the severe symptoms and radiographic appearances that I showed earlier. So you have a patient with severe community-acquired pneumonia who got admitted to the hospital. And you've exhausted all your investigation workup, and you don't think that this is a community-acquired pneumonia, this is something else, and maybe it is a cryptogenic organizing pneumonia. You need to think now, does the patient require mechanical ventilation or not? If the patient does not require mechanical ventilation, obviously they will be on ACV. And of course, if they do, then they will be on RTU. And on both locations, you will still need to give them pulse methylprednisolone. It will be the higher dose, the 1 gram per day if the patient is on ITU, and it will be 500 to 1 gram per day if the patient is on the lower level of care, for example, ACV. This is to be given for 3 days, and then you need to reassess your patient as well as reassess radiologically within 3 days and see if there is improvement in the hypoxemia, there is radiological improvement in the opacities, then probably you are, this highly supports the diagnosis and you are managing correctly or properly. In which case you have to transition from the IV prednisolone to oral prednisolone. The dose is 0.5 to 1 milligram per kg. But if after 3 days from giving the pulse methylprednisolone there is no improvement, then you need to reassess and you need to re-challenge your diagnosis. Is it cryptogenic organizing pneumonia or is it something else? You may need to resort to more invasive investigations, bronchoscopy, BAL, even lung biopsy. And if you still think that this is a community-acquired, this is cryptogenic organizing pneumonia, then you can go to the next step. If the patient is in a high dependency unit or a place like, for example, ACV, you can give them, they have not responded to the prednisolone or the steroids, you can give them azathioprine. But of course, before giving that, you need to do your TPMT level to make sure that they are not, they will not develop severe bone marrow suppression, and they can handle the thiopurine metabolism. If the patient is on the ICU, then you need to give them IV cyclophosphamide if you're still suspecting it is cryptogenic organizing pneumonia. And you also give them, along with that, methylprednisolone or oral prednisolone. On both levels, if the patient is starting to showing stabilization, then you will start giving oral prednisolone, and this will be given over a period of 8 weeks, and you taper it gradually until it reaches 0.25 milligram per kg. Again, you need to continuously reassess and evaluate your patient by doing chest X-rays, pulmonary function tests, and this is every 8 to 12 weeks. And then if you feel that the patient still needs to be on immunosuppression, then probably you can transition from azathioprine to mycophenolate, Mopitel. And if the glucose-sparing agents, sometimes you also continue the steroids for a longer period if the glucose-sparing agents are not, doing what they're supposed to do 100%. So basically, this is how we go about the management of cryptogenic organizing pneumonia. the take-home messages are when you're not behaving the way it should, then I think we should think about organizing pneumonias. But of course, after we excluded all the common possibilities. And even when we're thinking about the organizing pneumonias, if there is no clear etiological cause, then think about cryptogenic organism. Thank you.
Nice presentation. I just want to add just a bit, to whatever she said. So, cryptogenic organizing pneumonia, it's a part of the interstitial lung disease group. So we divide the interstitial lung disease group into known causes, which is caused by the drugs or the occupational causes. Okay, and then we have the non-known causes, which we call as the IIPs, idiopathic interstitial pneumonia. So then we divide the IIPs further. The most common is the IPF, which is the 80%. Okay, and then we have MSIP, and DIP, NIP, and then one of them is the cryptogenic organizing. They are, but in ICU setting, they're not very common. In respiratory setting, they're fairly common. And what she said rightly is that presentation is very difficult. So the diagnosis lies in history. It's history, history, history. And the third thing you want to look is the radiology. So history will be the patient will come to you. They are not particularly unwell unless they have blood infections or underlying either the inflammatory conditions or the atypical infections. Usually they come in and they give you a very typical history of 6 to 8 weeks. They take antibiotics, they get better, they develop pneumonia on the chest. Right? They take antibiotics, they get better, they develop. But it's not about the antibiotics that tend to improve their symptoms. The symptoms tend to persist. It's just as radiologically they tend to improve. Diagnosis is so you do the radiology. So history is one. The second is radiology. So when you do the radiology, you will see the patchy consolidation that possibly here and here. And what you start to say is they've taken the antibiotic, now they come back, and you compare those chest X-rays and says that she's been coming in for the last 6 to 8 weeks with patchy consolidation of different locations. She gets antibiotic and she doesn't get better. Okay, so that's the hint from history and diagnosis. Radiology, what you probably have missed, the only thing is the reverse halo sign. So if you do the CT scan, so what do you see in CT scan? So you see, if you see a consolidation, they usually have a dense consolidation, and then surrounded by a dense consolidation is a ground glass change to light, and then there's a black line. Okay. In their case, it's about 25 to 30, 40% patient usually develop the reverse halo sign, which means their center would be ground glass. It's not as dense as the periphery is. Okay, so, but that is only 20, 25% of these patients. So the hallmark diagnosis of these patients is on radiology is one is patchy consolidation of different locations, and on CT it's the reverse halo sign. It is still the diagnosis of exclusion. They do tend to get discussed in the ILD-MDTs, but ILD-MDTs they take very long to one is to get into the ILD-MDT. By that time, if there is no contraindication, just give them steroids. Give them a hypertensive lab, and the response is within 24, 48 hours, you see, they just get better. The symptoms tend to improve. They normally, the age is the other thing, that they are most common in people in their 50s, 60s, normally around someone who comes in 50, 55, 60, are the most common with the cryptogenic organism. And then they normally then, once they get treated, they get home, they go to gantry, they follow on the ILD, and that would be about 8 months follow-up if you're lucky. Usually the waiting time is about a year. And then they get investigated. They will get fully function tests and all those things, and then they get all of the extended ENA scan and ANA scan and vasculitis scan, and you want to rule out everything. They usually get a very detailed history when they get to see in the ILD clinic. Sometimes they just recover once, and sometimes they require long-term steroids as well. And then whatever you mentioned in terms of cyclophosphamide and everything. And then the biopsy I have not seen, usually they're not very keen to do the biopsy. It's mostly the diagnosis of exclusion. But you tend to get up, because I say they are part of a group of the IIPs, which is the idiopathic interstitial pneumonias, which IPF, NSIP, DIP, and then COP, all of that group. And then you have to differentiate between which group is that. So, and it depends upon, at that point, they sometimes mention about the biopsy. They don't normally get biopsies easily because the risk of biopsy with these patients is pneumothorax. So you can tend to develop this quickly become pneumothorax. They can develop pretty quickly. They remarkably response to steroids. You give them film and hypernissolone and then over, they usually respond very well. And then she mentioned about the secondary causes and limits. It's more of a so reverse halo sign is very interesting in these patients. We see them, we see goals of them, and then the other thing is their history. So if you're good at history, I think so the moment someone comes to you and he tells you this thing, you take a very detailed history. So what happened? Which and they will tell you they have taken antibiotics, they got better, and then they find sometimes they do not have underlying condition, cystic fibrosis. It's difficult when they have that because then they have already got distorted chest X-ray. But it's usually is the history and then the CT scan of chest X-ray, which was question. You just and most of the time we don't know. We just give them steroids, they get better, they get diagnosed with what, and then follow up and then the ILD on this stuff.
Is there, yeah, go ahead.
How, presuming they respond well to the methylpred,
Yeah.
you then switch into oral pred, how long do you usually keep them?
So as I said, it's normally dependent upon the response. So normally you give them methylpred, okay? So methylpred, we normally give them a couple of doses, and they usually start up with the pulse methylprednisolone, 1 milligram per day. And then after that, you give them pulse methylprednisolone to get their response. Now, if they have got a decent response, now technically you want to keep them on some weaning dose of steroid. Now, weaning, you can start off with 30, bring down 5 milligram every 5 days, every 3 days. Again, it depends upon the response. And then you just wean it down. And then what you say to them is when they come to 10 milligrams, is if they develop a similar presentation, a similar on chest X-ray, they have to be on 10 milligram until they get seen by the ILD team, which got a class they get to see them.
And also to answer your question, it can be as long as 6 months to 1 year.
Yeah. It again depends on how the complex. If the patient gets in, you get treated, and then being on steroids successfully, then that's it. You don't have to give them anything else. But they normally end up in having steroid 10 milligram and then HPXs and then their cortisol gets lower down, and it's so difficult to get them. There's a protocol in plenty to gain them down and get them. That's probably it.
Is there a role of surgery or lung transplant?
No. If there is an underlying condition, not because of the cryptogenic organism. As I said, they usually respond very well to steroids. Steroid is the only treatment. So unless there is an underlying condition that is required, cryptogenic itself is not for because they don't last very long. It's not very chronic, and they're not particularly unwell. If you look at them, if they have got not cystic fibrosis or bronchiectasis, then they look well. If you look at them, they say you've got someone who's got so much dense concentrations, but it's like 2 liters or 4 liters of oxygen, and not particularly fast. They might be taking but they'll tell you that it's not take antibiotic, but apparently it's not the antibiotic that is healing there. So that's the secondary history. Apparently it's not the antibiotic that treats, unless there is a secondary bacterial infection, it doesn't treat them. It's primarily because this is how cryptogenic organisms decide to keep the change on the condition. But if you find a reverse halo sign on a CT scan, which they mention the you can actually even open the radiopedia and then they show us what the reverse of cryptogenic.
Thank you.
Thank you.
Thank you.